Welcome and thank you today for coming to this CHEST webinar related to COVID-19 disease in children. We're excited today. We've got a distinguished panel of 3 members, and we are looking forward to learning a bit more about how COVID-19 has impacted children, both directly and indirectly, as well as learning a little bit more about the clinical characteristics, manners in which you can diagnose the 2 different entities between acute COVID and MISC, as well as further delineating some of the immunologic understanding of the disease in children, and then perhaps positing different hypotheses of why children may be affected differently than adults and how this may be impacted by different mutated strains as we move forward through this pandemic. So before I move forward, I just wanted to introduce myself. I'm Dr. Ken Remy. I'm at Washington University in St. Louis. I'm an adult and pediatric physician scientist at this university. Next up, I'd like to introduce Dr. Janine Z. Cheng.
Hi, I'm Janine Z. Cheng. I am a peds intensivist, recently turned primary care pediatrician, and it's based in Indiana. Very nice to meet y'all.
Next up, I'll have Dr. Yanka Bullet introduce herself.
Hello, my name is Yonca Bulut, and I'm a pediatric intensivist at UCLA Mattel Children's Hospital, and with the primary interest with the iron and iron biology and infection. But of course, now the spotlight is on COVID. Today we'll talk about the COVID and of course MISC.
Thank you. And then finally, Dr. Adrienne Randolph will introduce herself.
Thank you. I'm Adrienne Randolph. I'm a pediatric critical care physician at Boston Children's Hospital and a professor at Harvard Medical School in anesthesia and pediatrics. And I lead the Overcoming COVID-19 Investigators network that includes about over 60 hospitals across the United States studying severe complications of COVID-19, including acute COVID-19 and multi-system inflammatory syndrome in children and adolescents, and in centers in the United States. And we have 2 big studies going that include a huge registry of over 2,000 patients, as well as an immunobiology study that's enrolled over 500 patients. And that's where I am able to answer questions related to any complications in children and adolescents.
Thank you, Dr. Randolph. We're most also appreciative of Dr. Christopher Carroll, who's not with us today, but he was able to put forth this panel, which I think he did a phenomenal job of putting together a very unique panel of experts within COVID disease and how it relates specifically to children. So for the next 40 minutes or so, our hope is that we're going to tackle a number of different areas. The first area I'd like to talk about would be the impact of acute COVID directly with children and on children, as well as indirect consequences of disease. And as we move away from acute COVID disease, we'll next move into further understanding of multi-inflammatory syndrome, or MISC, in children, and then further understand and delineate those immunologic consequences as mentioned. Before we begin, what I will tell you is in your current chat box, if you've got additional questions, I will be looking at that chat box throughout the talks by each of our panel members as I ask them specific questions, and we will take those questions and add them in towards the end. Additionally, there were a number of questions that have been submitted, and we've attempted where possible to try to integrate those into the questions for the panel already. So without further ado, I'm only going to speak for a few moments just to bring forth just an understanding for the group of some of the epi data related to COVID disease. And when we look at COVID with the early data from the beginning from MMWR from June of this past year, children do get COVID-19 disease. And I know that this is, it's not surprising to everyone on this webinar today. However, the numbers originally and where we sit today have slightly grown from the original data that demonstrated that 1% of the cases in the Netherlands and 2% from a large observational cohort in the UK were children under the age of 18. Additionally, back in April of 2020, 1.7% of all confirmed cases of COVID were less than 18 years of age. Furthermore, 90% of those cases were acquired from household exposures, with about a 14.7% secondary household attack rate in China and about a 27% increase attack rate, if you will, from household exposures in New York. In the United States at that time, about 5% of all cases in children were less than 18. And if you look at the epi data back then, very few cases across the entire cohort of United States individuals with SARS-CoV-2 infection were children. Additionally, unfortunately, and much of this has remained, if you look at the first wave of COVID, many of the deaths, fortunately, were not in the young children age of between under 1 year, as well as 1 to 4 and 5 to 14 years. This just came out in the CDC over the past few months. And what you're looking at here is the risk for COVID-19 infection, hospitalizations, and death by age group. And the reference group is that 5 to 17 years of age. And you're looking at change in risk specifically from 0 to 4 years, as well as the adult counterparts of greater than 18. Now, this is for acute COVID. And as you can see here, the 0 to 4-year-old patients have a 2 times higher likelihood than the reference group for being hospitalized, and a similar one-time compared to the reference group for mortality. And you can see logarithmically how this will increase as people age. So what are the numbers as of April 22nd, 2021? So we've seen a little under 4 million total children with COVID-19 cases reported, and this represents about 13.7% of all cases, with an overall rate of a little under 5,000 cases per 100,000 children in the population in the United States. When you look over the past few weeks in change in number of cases, 79,800 new child cases were reported from April 15th through the 22nd, and this represented about 21% of the new weekly cases. Additionally, when looking at testing, children made up approximately 6 to 19% of all total state tests, with about 5 to 30% of those children that were testing positive. And then finally, with mortality, children still remain, fortunately, with a mortality less than 0.19% of all COVID-19 deaths, and 10 states are currently reporting 0 child deaths. This is at least fortunate, as children seemingly don't have the same level of severity of illness as their adult counterparts. So in this, I'd like to ask Dr. Zicheng and Dr. Randolph a few questions. Would you mind commenting on how children have been impacted directly from COVID disease? And then the second follow-up question will be indirectly, and then we'll get into the specifics of the disease as far as clinical characteristics of the disease in children. Thank you. Either person can take that first.
Janine, you want to go ahead? Or I can.
Yeah, so
Sorry. Go ahead. Yeah.
We actually, so I'd like to acknowledge, first of all, Dr. Carroll, who's has not joined us today, and we sort of put together about a year ago a project to look at the indirect effects of the pandemic on children, and we used the Virtual Pediatric Systems database. So shout out to them. That's a big database that is dedicated to standardized outcome data sharing among PICUs. So we looked at 160,000 children who were admitted to 77 PICUs across the country in the first 2 quarters of 2017, 2018, 2019, and 2020. Grouped the 2017 and 2019 data together to compare it and we used a weighted average for those data for those first 3 years, and looked at those in terms of admissions by diagnosis to the pediatric ICU. I'm going to share my screen here and show you kind of what we came up with in terms of indirect admissions. Now, that first quarter is what we'll look at first. And again, this is January through March of 2019. 2017 through 2019 is the light gray there, and 2020 is the dark gray. So as you can see, between quarter 1 and of 2017, 2019 and quarter 1 of 2020, there was not too much of a decrease in PICU admissions. Frequency of admissions differed significantly in only 5 diagnoses there. And so that was, kind of in March was when states started implementing mask mandates and there were school closures. People were starting to physically distance and things were beginning to shut down. And so as we're moving towards from the end of quarter one, which I'm showing here, to quarter two, if I can advance here. So this is looking at quarter two. And again, the light gray is 2017 to 2019 and the dark gray is 2020. And you can see pretty significant decreases in the 2020 quarter two in a number of different diagnoses. We're looking at, particularly respiratory illnesses. So asthma was 6.6% of patients in the 2019 block, down to 1.8% of patients in 2020. Bronchiolitis went from 6.5% down to 0.9%, so pretty significant decrease. Pneumonia, influenza, respiratory failure, and arrest all had decreases. There were some interesting increases as well. So increasing in some in brain trauma and in general trauma, and then diagnoses that had significant increases in both frequency and in the raw numbers. So when you look at those actual number of admissions, diabetes was a big jump from 5.1% to 9.4%. Poisonings and ingestions went from 4.3 to 6.9%. So, we know that with all of these changes that came at a societal level, we know that there were decreased levels of vaccinations, decreased visits to emergency departments, decreased primary care visits. And so it's just interesting to see how all that played out in terms of admissions to the PICU. Additionally, when we looked at all those numbers, we put together a multivariate logistic regression model for factors that are associated with mortality. So PIM2, pediatric index of mortality to age, race, medical versus surgical, scheduled versus unscheduled. So mortality was not associated with the study year in if we looked at quarter one data, but going to quarter two. So this was the thing that, obviously we don't have enough information to really explain it fully, but the odds ratio for mortality in COVID-19 quarter two was 1.17 compared with pre-COVID-19 quarter two, so the 27 to 2019 block. And, we know that all the hospital systems were very strained. Healthcare workers were stressed out. We were not, in a lot of cases, able to go into patient rooms as frequently as we would have liked to because of, the risk of transmission. And then the other interesting thing that we noted when we ran this model, and I think there was a question that had been submitted about race and ethnicity in COVID, was that when we looked at the model, non-white children and neonates had increased odds of mortality. So we've got some pretty interesting numbers from a pretty big data set, and obviously we can't answer all the questions that we'd like to about what exactly caused that. But that was what we came up with for that study. So Dr. Randolph, I'm going to pass it over to you.
Yes. So I think that, as far as are children really at risk and more severe, first of all, children have always done better with sepsis and ARDS and everything else, right? But we started tracking deaths in influenza when we had an up year in 2003, where 300 and something children died. And then we started tracking deaths from influenza, and that was a lot. No, we don't have thousands and thousands because you wouldn't expect that, and that would be really shocking. But as more and more and more of these elderly adults are vaccinated, you're going to get the death rate there is 30% or higher. We don't have that. We don't have if they get into the ICU with flu in a bad year, our mortality rate would be 8%, in a bad year, with a vaccine mismatch or something, or bacterial co-infection. But despite that, I just want to bring us back to what is usually, aside from the pandemic, things that we are concerned about is hospitalizations, right? Lung disease in children early in life, which we know has long-term sequelae, neurologic impacts in early in life that can have long-term sequelae. And if you look at the numbers, children aren't completely spared. And as we get more and more into the fact that they're probably going to be one of the only major populations left completely unprotected, and the variants are of concern in the virus as it mutates is affecting younger people. We have now left a population of our youngest individuals completely unprotected. If something changes and it gets more severe, which it does seem to be doing in some countries and Michigan and other places, affecting younger people, right? So people like, so I think that, people like, my mother got COVID. Thank goodness she did okay at age 82, because I was really scared for her, knowing all the data that she had 1 in 3 chance of everything going wrong. You wouldn't expect that in a child, but as all these other people get protected with vaccination, they you just left a completely vulnerable population. Plus the fact that Miss C seems to be occurring mainly in these younger patients, although there is some Miss A, who knows what, but we have this post-infectious complication. So, I think that just getting back to be pre-pandemic, when we weren't just our heads swirling with, 500,000 people dying, and we were just dealing with hospitalizations and our usual outcomes and everything else, I think we're going to get back to that. And then we're going to be dealing with who's at risk, how do we prevent it, and the fact that we never got any treatment trials, zero in children. We're using it though. I can tell you from data that I have if they're in the ICU, over half get some COVID targeted treatment based on adult data. We never did any of our own studies. We're talking remdesivir, steroids, whatever. We never did any of our own studies, right? So, and we didn't have the numbers to do our own studies, right? So we're extrapolating. We don't know if it works. And then the same with vaccines. We're going to be stuck with case control studies, right? We're not necessarily going to do big trials. We're going to probably implement and do case control, we have a little bit of a trial in the 12 to 15, but it's small. And because the incidence is small. And then we're going to do test negative control studies, which we were just funded for with the Overcoming COVID with a bunch of money from CDC to do a big test negative control. So I'm not saying negative. I think it's good that we're doing something, but it's just because our incidents are low, and to prove does it work or not work and protect. So anyways, I'm just saying that in a usual year, you would still be concerned about a lot of these complications and issues. And it's just that you get so bombarded with and luckily that's going away. Thank goodness that we've gotten control over the death rate and everything in the older people, and many of them are vaccinated and protected. But now we have left a completely unprotected population. If the virus mutates, we have left all of the children unprotected.
And to kind of go off of that, Dr. Randolph, because with our data, when we were looking at those decreased PICU admissions, decreased by 30% in quarter 2, and that was when all of our safety, our we're all on high alert, and everybody was wearing their masks and things were shut down. And now as all of these groups get vaccinated and we're peeling back those layers of safety, those two combined effects, possibility of mutation and the addition, and this feeling of security that we're going back to society and reopening and people are traveling again, then what are the consequences of that?
I think these are excellent questions. And so in relationship to this, and I think the mutation one is very interesting, specifically because a lot of the data that we have is from D614G, and it's not necessarily with the B117 or the P.1 strain mutations, although there is obviously data in the last 2 or 3 months as far as infectivity and transmission among children. What I'd like to understand, so I've personally taken care of about 2,200 adults with COVID thus far, but I've only taken care of about 23 children that have had COVID in the intensive care unit, at least acute COVID, not MISC per se. From your clinical experiences, are there differences in the presentation for the children that you've taken care of? Are they different than what we would normally see with some of the adults that come in with tachypnea, that have certainly hypoxemia, that have altered mental status, and have GI upset or nausea, vomiting, plus or minus fever? Are those symptoms for acute COVID anything different for children than at least what I've experienced in adults?
I think that, yes, there are some differences depending on age in our registry. And I can share that because we're now looking at the infants a little bit more intensively. The teenagers seem very similar in what I see to the adults. Comorbid conditions, even diabetes, obesity, a lot of patients over 30 BMI, 40 BMI, a lot of risk factors that were highlighted in the adult populations. Chronic lung disease, chronic neurologic disease, as well as to why they get in the ICU. But then there's this other huge peak in the infant population that is more like, when you think about RSV bronchiolitis, if you're pediatric, what do you think about what gets you in the hospital with RSV bronchiolitis in the ICU, et cetera? It's a totally different thing. More previously healthy kids, younger, under 1 year of age, needing oxygen and other things, neurologic complications, lung complications, other things that, they're definitely concerning. And we know that in RSV, those ones that get lung disease can often, half of them become asthmatic later on, whether it's related to RSV or just they're picking out people who are predisposed to asthma, whatever. But clearly it's a different phenotype, maybe more similar to our other infant phenotypes of who ends up in the ICU infant with lung disease or neurologic disease or other things. It's clearly, there's clearly a peak there. So I do think that there's there are some epidemiologic signals, and I don't know what the long-term sequelae are. I do know that there of these kids that come in with the lung disease that seem to have not such a bad pneumonia, that like if flu, and I have followed these kids with flu, and I know that when you follow them up, they seem to do fine, right? They're not on oxygen. They don't have shortness of breath. They don't, with the COVID, some of them have follow-up CT scans like the adults, ground glass, shortness of breath, all this stuff. I've been doing flu research since 2007. I have not seen all of that, even when somebody has a bad influenza pneumonia, compared to this, which is more similar to what you see in the adult population. So there's something about this virus that seems to linger compared to the flu and some of the other viruses that we usually study.
So in comparing the long haulers that we see in the adult world, certainly with the advent from June to present with use of dexamethasone, I'd be curious to see when dexamethasone is used with acute COVID children, does your data or your findings thus far demonstrate that these sort of long hauler children who may have not had as severe of a case of some of the long haulers we see in the adult ICU that are lingering for 2, 3, 4 weeks inpatient, but are you seeing things such as new development of reactive airway disease or asthma or other related diseases? Are we seeing secondary infections in these populations similar to what we would see also in the adults?
See, we don't have the numbers that you have in the adults of all that lung disease. And we have very few intubated patients. Okay. So, I mean, the stuff that you guys are reporting with the people had severe lung disease, et cetera, not that many are intubated, right? I'm talking about people who were on the ward with the pneumonia, who still are having issues and shortness of breath and going and being followed up by pulmonary and having a lot of stuff. That we would not see that kind of thing with just a flu, right? And even in our severe flu in the ICU, most of those people recover and don't necessarily, some of them do, but most of them don't necessarily complain of all of these shortness of breath and symptoms like this. So I think that these symptoms that the adults are complaining of, although we have many fewer because I have this registry and I have this network and we're doing follow-up, I do get all this information. I mean, it's way more than I would expect in my flu cohort or I've seen in my flu studies. So there's something about this virus that does tend to linger and cause some issues. And these kids weren't as sick as the adults that you're describing. They don't get intubated as much, or they may not even have been on non-invasive, just oxygen on the floor with infiltrates, you know?
No, absolutely. I think this is a great segue for Dr. Bullitt to come in and discuss a little bit about why children have better clinical outcomes with acute COVID disease or SARS-CoV-2 infection. And then are there similar immunologic findings that we see in children as compared to their adult counterparts? Love to hear your thoughts.
So what is interesting is that there are certain things that we thought that is the reason that the children are less, affected by the COVID. And one of the theories where the children have a reduced expression of ACE receptors. And why is this important? Because we thought that spike protein is utilizing the ACE receptor and another protease tempress to enter the cells and infect the cells. And then there's this famous JAMA paper from last year showed that the nasal epithelial cells of the children had less ACE receptors. However, that study was from a couple of years ago from actually an asthma group, and they showed like less than 10 years old children had less ACE receptors, but the adults, when they call the adults is greater than 60 years old, they didn't have data for the greater than 60 years old. And then there's a recent study that actually came out this month that showed that from the Betsy Herald group that these two important receptors, the ACE receptor and the TMPRSS2, gene expression is similar in children and adults. And also there's another group, that Zhang group, that showed that actually decreases in the ACE receptors, decreases in the elderly. They call elderly greater than 50 years old, which I don't agree with. And then in that group. This lower ACE receptor story may not be the case for the differences, the reason for the differences. And also the patients with underlying diseases such as diabetes who have reduced ACE expression, and then the risk of severity is increased. And the other theory was that this anatomical differences, that if you have greater resistance because you have smaller airways, so that this may lead to less aerosol particles are deposited in your trachobronchial tree. But again, this has been refuted because this group from Montefiore that showed that when they look at the nasal swabs of these patients, that they showed less RNA in their nasopharyngeal samples. And then there was this study from last year again that showed that the greater than 5 years old, they may have actually higher numbers of RNA detection of the SARS-CoV-2. And then there's another theory, the cross-reactivity. In this found that if the pre-existing immunity to the common coronaviruses may be protecting their children, it's another possibility. The study group from the La Jolla Institute of Immunology showed that there are a lot of people that have pre-existing immunity to SARS-CoV-2 in unexposed individuals. These are pre-pandemic antibody levels. But the same group, the peers, is just they showed that this did not differentiate between the adults and children. And then in addition, there are other studies showing that even if they are elevated, they are not protective of the severity of the disease. So if we have these differences, so what is protecting children? So this, I will share this new study from this month, and then a couple months ago that this group, they looked at these children with the hospitalized COVID and then adults. In the first study, they looked at serum levels of the IL-17A and interferon gamma, which is very important in the disease control. And in pediatric patients, they had higher serum levels and then lower serum levels in the adults. And the next study of their follow-up study, they also looked at the nasopharyngeal samples, and they look at actually the expression of these genes and the proteins. And they show that they have increased interferon signaling in NLRP3 inflammasomes, which will be fighting for the immediate innate response. These children had increased interferon, IP10, IL-8, and IL-1 beta in their nasopharyngeal fluid, and compared to less in the adults. And then one theory was that the poor outcome in adults were attributed to the not generating strong, robust T cell response to virus spike protein. But they showed that the adults mounted robust T cell response. They have actually high neutralizing antibodies, and according to some studies, even higher, and they have systemic levels of inflammatory cytokines. So this story is telling us that maybe the initial vigorous early mucosal immunity by the interferon IL-17A in children, initially giving us a robust innate immunity, but preventing for a more maladaptive adaptive responses in the future. And maybe it's the opposite is true for the adults, that initial delayed and ineffective innate immunity may be leading to more dysregulated adaptive responses. So this is the story so far about what is out there.
Thank you, Dr. Bolt. This is really interesting. So based off of that and understanding at least some of the descriptive and some functional immunologic studies that have at least evaluated the disease in children, have there been, and Dr. Randolph, please feel free to jump in, have there been any mechanistic evaluations in children that have been used with any, at least observational therapy trials? If not, obviously randomized control trials haven't been completed, but in any of the work that's been done thus far for children, do we have any insights, at least if there are therapeutic targets that have been at least attempted so far in kids?
Not that I mean, Dr. Randolph, would you like to?
Oh, you go ahead. I mean, so I think it's important first to distinguish between acute COVID-19 infection or MIS-C. So there's a lot of more known about MIS-C, I think, therapies, because there's an entire consortium and guidelines, et cetera, where the acute COVID-19 is a spectrum of complications in kids, like GI and, the respiratory isn't the same phenotype. Some of them are, but there's so few that fit the adult phenotype of ARDS that it's hard to actually do a therapeutic study. There, in general, I know that the data that we have show that for the ones that fit that respiratory phenotype in the ICU, they're basically extrapolating from the adult patients and giving remdesivir and steroids and et cetera. And early on in the pandemic, they gave hydroxychloroquine, A lot of kids got it, even young kids, even though didn't make, but they did. And then for Miss C, I mean, almost all of them get IVIG, and then half of them or more get steroids, and then there's some biologic use. And over time, there's more and more steroid use. And when you should do steroids, et cetera, is a whole different thing. And what are you treating? So I think it all depends, like what phenotype are you treating of the complication. And then there's this group that's kind of in between the two, and they basically have acute COVID, but as you know, is Miss C's like a heterogeneous definition that covers ARDS with multi-organ, involvement, like cardiac or any other, and inflammation, which are MODS, patients with pediatric ARDS. And so they get categorized as Miss C, right? And we just published this paper in JAMA February 24th about that, basically showing what distinguishes the two groups and showing that probably there's overlap there. And these are just acute COVID patients, our sickest of the sick HARDS patient, pediatric ARDS patients with multi-organ involvement and inflammation. And they are not necessarily post-infectious, they're infectious. They're what you see in the adults with the worst of the outcomes, right? So, and so that was our point of that paper and what really differentiated there. How do you distinguish the two? And it's near impossible, honestly, because the definition for Miss C is very vague. And we're not looking at, viral load and all these other things that, so anyways, I think it's so important, like what phenotype are we treating and how do we deal with these patients that are in the middle? And then we also have had these patients that were acute, infection in the lung, and then they morph into this, multi-organ it's not even post-infectious, they're still infected, but multi-organ involvement with the heart and other organs that just went on and on with inflammation and fever. And some of us, and I think in adults that's been described in young adults where they were getting better, and you might have taken care of some of those, Ken. They had lung disease, they were getting better, and then they just fell apart. And now I think the CDC is struggling with how you categorize Miss A, or these patients who are sick that then got better than worse, or these, patients in the outpatient that never had anything. Like in the children, these were mostly previously healthy kids, didn't have anything, but were PCR positive a month ago or antibody positive now with an exposure, and now come up with cardiovascular involvement. And the adults, I think they're categorizing out more of these patients that had lung disease. They were younger, they got better, and then they just fell apart, So I think this is important because these are kind of our ARDS patients. This is our bread and butter type of patients for lung disease that we treat and manage.
So I appreciate the mentioning now of Miss C. I'm going to take a step back just for the audience. If you wouldn't mind, take us through how we came to this concept of Miss C and how one can differentiate it now clinically as best against acute COVID. And then are there specific clinical findings in Miss C that are very different than acute COVID? And then the final question is, and this is more of that $1 million question, is this a new entity? Why this virus? Have you not seen it in flu, or have we not seen it in RSV or other viruses? So just if we could take that step back, Dr. Randolph, could you just take us through at least how we arrived to that there is this entity in Miss C or MIS-C or PIMS, and what a clinician is to look for to be able to effectively diagnose this, and then understand at least what the potential consequences are of this syndrome?
Yes. Well, let me just show just a couple of slides. I mean, that might just show sort of how heterogeneous the diagnosis is. So, first of all, let's just talk about the fact that this was 1 year ago, right? It's now April 29th. This whole thing came up 1 year ago. It came up because in mid-April, in Italy, London, and then New York City, they described these children with shock, right? A set of like 8 tiny numbers that presented with shock, etc. A month after Miss C. In general, children were very minimally affected by COVID early in the pandemic when everything was now coming into the UK and Europe and the US. But then there was these case reports. So they came up May 15th, this worldwide alert. There was the PIMS-TS, right? They call it Pediatric Inflammatory Multisystem Syndrome associated with SARS-CoV-2, PIMS-TS in Europe, Miss C, and then Miss C in WHO, right? So, and then, they had these Kawasaki disease features. So, as a pediatrician, you think Kawasaki disease features, whoa, what about the coronary arteries, right? Because, these are kids who basically had persistent fever and then a lot of them had coronary artery diseases, which is what you are concerned about, which is why all of them were getting IVIG, right? We're treating the heart here. That's why we're giving them all IVIG. And then steroids, we're treating them like Kawasaki disease, right? And we published this early on, putting a thing together very early on in June. And, here's the diagnosis. Very, very vague. Now, just to say, although this has a spectrum, and over time, as they mandated this to be a publicly reportable disease, less and less sick kids got reported, right? Because early on, when we made this report, most of these patients had 4 to 5 organ systems involved. Most of these patients had multiple biomarkers of inflammation. The average minimal duration of fever was 3 days. And, these were sick patients. 80% in the ICU, 50% in shock, and 10% developed coronary artery aneurysms. Now, we thought we were seeing Kawasaki disease. Everybody got very, very, very scared that we were seeing a vasculitis. So people were hammering at this with steroids and with IVIG. And these were bigger kids, right? Because Kawasaki disease, you hardly ever see shock. 50% of these kids had shock. And steroids, right? So, but what the case is that in our JAMA paper from February, we followed all these kids out. And most of this coronary artery disease and the poor function on echocardiogram was very short-lived. Where in Kawasaki disease, the coronary aneurysms are more persistent. Becomes a lifelong problem. So and there's other reasons to think that it's not exactly Kawasaki disease, right? I mean, we did see this distribution, and whatever reason, why is this happening in this middle-aged child distribution and previously healthy kids? There's these concerns, but the more we looked at this over time and looked at it compared to acute COVID-19 in our JAMA paper that we later published, we saw all this overlap in some of these patients. It's hard to tell. Some of them do meet criteria for acute COVID-19. So anyways, I think that it's a brand new, very heterogeneous disease. And as you start public health reporting, you get a broader spectrum, including kids that are barely meet the criteria that we've all seen those kind of kids in our ICUs. And so I think it's time to revisit, honestly, this diagnosis and think, because And as we get further into it, and as people get vaccinated and kids get vaccinated, things are going to change. And how are we going to deal with that? Everybody's going to have antibodies.
Right.
Right. So how are we going to deal with that? I mean, I can tell you with flu, yes, I have kids who came in with flu that only had chalk. In my, PIC flu studies, we have a decent number of those, not huge, but quite a few. I mean, it can cause a myocarditis. This was definitely, I don't want to minimize, because there's definitely patients who clearly meet the criteria. There's something there that, oh my goodness, and you better pay attention, because they can get super, super sick, and they can get arrhythmias, and they can die. They can have arrests, all kinds of complications. But when you start having this broad of a criteria and saying that every single patient needs to be reported, you get this spectrum. And then you start seeing overlap with a lot of our just bread and butter stuff, No,
absolutely. Dr. Bullitt, if you wouldn't mind piggybacking on that and just tell us a little bit about the MIS-C immunologic understandings, at least which has been reported thus far.
I'm just gonna share it here because I'm trying to summarize what is out there. So I'm just gonna try to summarize the whole what is out there for an explanation, possible explanation, etiologies in one, and then maybe like an immunopathology slide too. So one of these hypotheses are not mutually exclusive. One of the hypotheses is a post-infectious autoimmune response from cross-reactivity between viral antigens and host antigens. Other possibility is like a dysregulated immune response to an ongoing viral replication. There's an unrecognized viral reservoir or a response to the superantigen. And then maybe like a little bit mimicking the adults that they are finding RNA data in 2-3 months after the infection in the gut epithelium and the biopsies. And then other possibilities maybe as a genetic predisposition. So what are the studies that's supporting this is post-infectious autoimmune diseases that these patients have high levels of neutralizing antibody IgG and IgA, but lower IgM levels. And this is Dr. Randolph's study actually here. And the lower viral load, meaning that the high CT count, but lower viral load in the MIC versus the acute COVID. And then no detectable levels of viral RNA. So that this is not an acute infection, it is a post-infectious phenomena. And then there are other studies that showing that there is specific autoantibodies targeting certain tissues, like anti-endoglin and MEP kinase and anti-Jo and anti-La. These are the possibility of the autoantibodies, but these studies are very small. Some of the studies with an N of 3 or 6. So we don't know that if this is the reason for MIS-C, or is it because of the immune response that we are seeing this autoantibody. And the other possibility is that the inability to eradicate infection, the persistent infection. Virus is gone, but there's a parts of the virus is lingering, and this may be due to the poor initial response. What is supporting this is that the Spiceberg group showed that there's reduced neutralizing antibodies, and maybe that led to an incomplete eradication. But there are other studies showing that may not be the case, that they have equal okay number of the neutralizing antibodies. And other interesting fact in this group is that when you look at the convalescent adult patients, the plasmablasts return to the normal level after 3-4 weeks. But in this MIS-C group, we are seeing that they are still elevated. And this is pointing out to a more of a dysregulated B and T cell response. And maybe that is driving the autoantibodies and the IgGs towards the endothelial cells. And then the last one is the possibility of the superantigen that I will talk about, and then the possibility of the genetic predisposition. To date, majority of the children affected with MISC are Hispanic, Latino, or non-Hispanic Black ethnicity, while Asian children are not affected. So there is a hint in one of the small studies that there could be some HLA genotyping of these patients demonstrating a T cell receptor be like expansion. There's like a shared HLA class 1 allows in that study. I think Dr. Hernandez will talk a bit more about that. When we look at the immunopathology of this, so that there are innate immunity is involved, adaptive immunity is involved, and then all the kids with MISCs pretty much has lymphopenia, and it's probably a post-viral activation, cell death, or chemotaxis. I'm not going to go over to every single cytokine in this picture. It's a nice picture from Lucas' group that in the innate immunity that you have increased alarmins. There is decreased antigen-presenting cell markers, and there are increased CRP and ferritin, increased cytokines, depending on which paper you are reading in which part of the disease, since the disease is so dynamic, as Dr. Randolph said, at which time point you are getting your information, that different cytokine levels is elevated for different patient groups, more like in IL-10 and TNF-alpha, more in the MASC versus the acute COVID versus the soluble CD25s, IL-18s, and CXLs, and MAS and HLH group. And then when you look at the adaptive immune side, that there is lymphopenia, there is decreased CD4 and CD8 cells. Although there is decrease in the B cells, there is a proliferation of the plasmablasts, which is probably translating as increased IgG1 and IgG3, which is autoantibodies towards endothelial cells and other tissues with increased E-selectin, and which is translating to the clinician as increased troponin and increased BNP. Lastly, that the superantigen story, this is interesting actually, because if I just go over the slide 2 seconds, that the SARS-CoV utilizes the ACE receptor with the temperus, and then the temperus cleaves them to S1 and S2 trimer. So what they find, the RDT and Bahar group used a structure-based computational model and identified a superantigen-like motif here in the red, where the S1 and S2 the cleaves. And this superantigen-like region is capable of binding to variable region of the T cell. So, and it causes a non-specific T cell activation, proliferation, and the release of the cytokines. But the interesting part is that the superantigen-like motif here that you are seeing has remarkable similarities to the staphylococcal enterotoxin B superantigen. And we all know that the superantigens are highly potent T cell activators, and exposing to that will cause non-specific T cell proliferation, activation of the T cells. So this is a possibility that this response is due to these superantigen-like motif that only SARS-CoV-2 has. And in MISC patients, that this T cell receptor is shown that to be expanding. There's a T cell receptor beta variable gene expansion. And more severe the cases that they are seeing this expansion in these kids. And then this may also explain the efficacy of the IVIG, because there may be the anti-staph enterotoxin activity present in the IVIG preparations, which antibody in the IVIG neutralizes staph enterotoxin, which cross-reacts with the SARS-CoV-2. So this TCR report is doing, which is correlating with the superantigen, actually shown with another group. Again, another paper came in. The 2 papers came out this month from and they are showing the similar information with these T cell receptor skewing and maybe causing to this dysregulation of the T cells and the B cells. So we are learning. We don't know. This is a very dynamic disease, and we only have this is a very rare disease. So we don't have absolute information, but there are overlapping stories, and the overlapping stories are that possibly post-infectious and autoimmune, and that there's a dysregulated immune response, maybe due to viral reservoirs that maybe is overlapping with the long COVID in adults. There is lymphopenia, superantigen story, and then this dysregulation may be leading to autoantibodies, and maybe some genetic predisposition. This is what is out there so far.
Thank you. No, this is outstanding. So I think this brings us to a point, we've got a couple minutes left, but I think it highlights, at least to me, a couple of different points, and I'll ask a couple questions from the panel. But one is that, at least in my experiences, many of these children with MIS-C get better without any therapies at all. And there's a concern, perhaps, that some of these therapies, such as giving a corticosteroid for a patient who's got altered CD4, CD8 depletion or has T-cell exhaustion, that in fact you could be potentially leading towards the development of secondary infections, or if you're using immunomodulating agents such as tocilizumab or anakinra, that may or may not have a mechanistic specific causal pathway, that there may be deleterious effects. And so I think it beckons the bigger question, which is in children, the numbers have been small. We've based a lot of things off of really well-intentioned, thoughtful people coming into groups of making expert opinion, but that opinion may not be necessarily born out of mechanistic understandings, or at least it is known up to this point. Should we be treating children with MIS-C with therapies like corticosteroids or immune modulating agents or even IVIG? Or is this really a self-limiting disease and we should only reserve these for the most severe of cases?
I think only Dr. Randolph's data suggests that, the 2/3 of these patients are requiring ICU and 50% is requiring pressors. I think that I really like the ACR's American College of Rheumatology version 2 approach. In that one, I think the first line is IVIG, which I agree because of the possibility that we just discussed. But the steroids, they are starting with the low dose steroids even. So that if the child is not responding to IVIG, you have a patient with a high BNP, high troponins, they're in shock, they have a couple of pressors. So I think that giving that child IVIG is reasonable with this data. But that going to the high dose steroids, if the patient is not responding to IVIG, they are recommending a stepwise slow approach. And then most of the immunologists that we are talking about that more leaning towards the IVIG rather than the steroids. So the 1 to 2 milligram per kilo of the Solimedrol. And if there is no response, then there's a division that instead of going to 20-30 per kilo of the steroids versus the IL-1 inhibitors like anakinra. Most people are shying away from the IL-6. The reason IL-6 inhibitors, the reason being that they may be actually some worse thing with the IL-6 inhibitors in the Kawasaki data. So I kind of like, even for the anticoagulation stuff that I just in our practice, that following the ACR version 2, that makes sense because of the experience, the years of experience. But it's a very, there's only 3,000 children with this disease. So
Dr. Randolph, I know you've got a comment on this.
No, I think that this is the thing. I agree with Janka. This is a very heterogeneous disease. I think that if we don't behave consistently, we're not going to be able to track and look at outcomes, and I think that's why these ACR guidelines are very helpful for people to have at least a consistent approach. And I will say that it's like all these diseases that you're treating your one in intensive care and infections, you're treating the one patient that got away, that did poorly by over treating 10 to save that one from having that terrible outcome. And we are seeing some bad outcomes in these kids. There's kids with permanent heart block. These kids have heart rates of 40. Like, what's that about? After the whole thing, something's going on with the heart here. And I think until we know more, and there's this study called Music that is following up these kids at like at least 30 centers, including a lot of our centers, that we need to know that there's scarring of the heart, what's going on, because there's some bad complications here. And these bradycardia that's persistent, block, all kinds of things that, and then there's people reporting, that's why they're being so aggressive, that there's just a few that break through, you treat them, you stop, and then they come back even sicker. So that's why they're treating everybody. If we knew who to treat and not treat and what this was and had a better diagnostic criteria, I totally agree. And knew what was driving it and knew, then we'd be better off. But right now, I think people are going to have to overtreat to prevent these bad ones from happening.
That makes sense. So Dr. Zicheng, I'm going to give you an opportunity to comment. And I think what I'll ask the panel to do after that is just let us know what you think where the field should go with children and COVID and Miss C, and any other parting comments you might have for our audience. But Dr. Zicheng, you're next.
And I just want to, again, Dr. Randolph, thank you, because you're saying such nice things that I'm just able to kind of segue into to what I was going to comment on is, kind of talking about this treating the one that got away. And this is where my sort of transition from ICU into primary care, when we kind of zoom out, the recent number is that 40,000 children have lost a parent to COVID, and which is a number I can't even wrap my head around, which, the additional stressors of being away from their friends, having the anxiety of especially parents who are healthcare workers or who are essential workers and don't have the opportunity to work from home. The stress levels in these children is extremely high. And to say that there will not have to be societal changes to help these children, whether it's, child survivor benefits or increased support for counseling, availability of therapists in schools, to think that those things, we'll be able to move forward without those things happening. I think that is something that really, as a society, we have to look at in order to maintain the health of all the children. Not just the handful in the ICU we need to treat, but also from a societal standpoint, it's important.
I think that's a fantastic point, because if you look at the numbers, that's going to be the greatest impacted by this COVID pandemic is certainly the group that you delineated. I think it's a phenomenal idea. And I think it's certainly an area that we need to at least refine as a medical community of what's the best approach moving forward to help those children that are going to be at risk for years to come of PTSD, depression, and a whole host of other mental disorders and illnesses that we certainly need to find ways, I think, to address it and address it soon. Because I think that probably we're behind the eight ball in at least addressing many of these issues with many of these kids who've lost grandparents or children. Dr. Bullitt, why don't you give your parting words, and then we'll go to Dr. Randolph.
Parting words is that we need to do more studies, longitudinal studies, and maybe international studies, because we are not in this alone, and then there are a lot of children that is affected. So I'm just hoping to collaborate with the international folks, friends, and go further.
Dr. Randolph, what else is on your list for how we move forward with this pandemic and with these diseases?
So, I think that it's really, really important that everybody pitch in and participate in these funded studies that are going on. There's 4 or 5 studies, more than that are going on to answer questions, because we never collected data. So I think it's really important to that we participate in studies. We need to understand, does the vaccine prevent against MIS-C and acute COVID, right? Is it going to prevent MIS-C, or are there going to be, other things, that vaccine complications that we have to monitor? So I think that there's a lot of, if it prevents MIS-C, that would be amazingly great, right? And then we also need to understand the treatment, because if these kids have myocarditis, they put them on the myocarditis watch that they can't do anything for 3 months and then they lose a lot of muscle. But then on top of that, you throw on all these steroids, and these kids often get weeks of steroids. Do we need that? How much do we? Kids, one thing, you're doing the acute thing and getting them out of it, but then how much do we really need to add on to that? Because that could have some consequences. So, I mean, there's so many questions here, and the outcomes of these kids and what's happening to their heart. And then there's just the acute COVID and the neural complications and everything. And then, as Janine said about, just the effects on these kids in general, I mean, oh dear, the social and societal effects. And those kids who do get sick have a lot of psychiatric effects. These MIS-C patients are scared, right? Should I get vaccinated? What if I get infected again? What about this? That's shown in that Great Ormond Street follow-up study that was just published. I mean, the anxiety about what happens to me now, about in these kids and how we support them and figure that out. We don't know. We have to figure that out. Are they at risk if they get infected again? Are they going to get sick again? So, because with the new variant, and then these new variants are something that we all have to be aware of and not let our guard down. And also, we can't think about what happened in April of 2020 and last year and what's going to happen this year. It could be a totally different world. We have the unprotected population now, right? It's mostly kids. So we could be the ones, if things change, we could be the patient population that gets sick. So we got to be aware of that. And we don't have any treatments. And we're not prepared, as usual. So anyways, those are my parting comments.
No, those are brilliant. If those that are watching this webinar would like to participate in one of your many studies, is there a website that they should visit?
Yes, they can go to overcomecovid.org would be one, or pickflu.org. Both of those then lead them to getting to our network, or just email me, which I'm not that hard to find, but you can go through the website as well. And yes, we love to have new people participate of new sites. We have a lot of sites, but everybody needs to pitch in to answer these questions.
Excellent point. And thank the three of you today for being part of this panel. For those today that are watching, first and foremost, our friends from India and from other locations that are having huge surges, please know that we're thinking of you, and feel free to reach out to any of us if you at least need some insights from our experiences. We're always certain, most of us are always available by email and happy to participate, at least in providing some consultation when needed. We're all in this together, as Dr. Randolph mentioned. And with that, I hope that we continue to try to understand the disease. I hope we start to stamp out the disease, and I hope we start to deal with some of the consequences of this horrible, tragic pandemic. With that, I appreciate everyone's time, and thank you for joining us today.